For the best possible results, how far would you travel? Would you take an international flight to find a hospital that ranked among the very best in the world for the treatment of heart attacks? For the best possible results in 9 cardiac care measures, just how far would you go? St. Tammany Parish Hospital, world-class healthcare, close to home.
Welcome to Healthy Living, brought to you by St. Tammany Parish Hospital. I'm your host, Amanda Paxton. We have 2 therapists here today to talk about some new services that we're offering at the hospital for our patients. Our first guest is Jenny Porter, a pelvic floor therapist that works out of our women's pavilion. Welcome, Jenny.
Thank you.
Can you first give us a little bit of background on yourself?
Sure. So my name's Jenny. I'm from St. Louis, Missouri, actually. Went to school in Springfield, Missouri, which is where I met my husband. He's from Natchitoches. And so when we were done with school, we were trying to figure out where we wanted to live, and he wanted to come back to the Southeast region where he went to college at Southeastern. So we came back here, and we've been here ever since.
Awesome. Okay, so I guess tell us what is pelvic floor therapy? I don't think it's something that most people have heard of before.
It is definitely not. We're trying to get more information out there, which is why we're doing this today. So pelvic floor physical therapy is physical therapy for your pelvic floor muscles. I know it sounds redundant, but your pelvic floor muscles sit on the bottom of your pelvis, and they support your pelvic organs and assist with your bowel, bladder, and sexual function. And so pelvic floor physical therapy really emphasizes the retraining of those muscles based on symptoms and the other problems that are going on.
Okay, so it has to do with core strength. I know everybody kind of talks like your core, and can you explain a little bit about how that plays into your whole core as a whole?
Absolutely. So everyone thinks of core as being their abdominals. They want that 6-pack look and all that, but it's more than that. Your core is more like a canister in your trunk. And so on top of that canister, you have your diaphragm. On bottom is your pelvic floor. In the front are your abdominals, and in the back is a muscle called your multifidus, and it's your back stabilizing muscle. And all 4 of these muscles and all 4 of these walls have to work together to maintain your core through our function in everyday life.
Okay. And so what does a pelvic floor therapist do?
So we are, first and foremost, physical therapists. So we are musculoskeletal and movement experts. So we can look at the person as a whole and see from a movement base and activity base what's going on, where you might have some weaknesses or some difficulties. And then we are specialists within the physical therapy world that we specifically look at the pelvic floor muscles. So we can do various assessments based on what's going on. We can look at your low back, your hips, your pelvic joints. We assess for scar tissue and myofascial restrictions. And then we do a specific assessment of those pelvic floor muscles. And this can be done a couple different ways. We utilize services such as biofeedback is one thing we can use to assess those muscles. We can assess those muscles externally, or we can assess them internally, because that's where the muscles are located.
Okay. And what are, I guess, some symptoms that someone would come to you with? Why would someone want to come see you?
Absolutely. So we can see men and women who have urinary problems like leakage or poor emptying of their bladder, or they're getting chronic or recurrent UTIs, bladder infections. We can see people for bowel dysfunction, to where maybe they have constipation, or they have pain with going to the bathroom, and then for sexual dysfunction and pelvic pain in general, or people who are having these chronic pain issues, so like low back pain that just never clears up, or they keep re-injuring their hamstring, or their groin keeps getting tweaked. There might be a pelvic floor component to that that's getting missed that we as specialists can really help with.
Okay. You mentioned like constipation, UTIs, and that sort of thing. Can you go a little more into that? Because it makes me kind of curious. You would never think that has to do with muscles.
Absolutely. So the pelvic floor muscles assist with your bowel and bladder function. And it's a muscle group that does both sides of that action. And so like when you are holding, like you're trying not to pee, those are your pelvic floor muscles that are contracting and squeezing. And then when we bear down, like we're going to have a bowel movement and go to the bathroom, those are the pelvic floor muscles that are doing what we call an eccentric contraction. So they should relax and lengthen, and having that control over those muscles and knowing what it's doing and is it doing when it's supposed to be doing it, that's what we're here for, to kind of figure that out.
okay.
Because these aren't muscles that you can see, you know, like you can look at your elbow, I can bend my elbow, see what my bicep is doing.
Right.
All these muscles are internal, so it's a lot more challenging for people to know and have a sense of what's going on with them.
Okay. And most of the things y'all do, are they exercises? Is it a lot of stuff to kind of keep you off medicines and kind of that sort of thing?
Absolutely. So we can work to try to avoid medications or in conjunction with medications based on what's going on. And we like to be a first line of defense for people who are also trying to maybe avoid surgery, or if a surgery is inevitable, like for a woman who has a prolapse or something, then we want to get those muscles as strong as we can in preparation for surgery so they have better outcomes afterwards.
Okay. And what kind of training does it take to become a pelvic floor specialist? Because I assume that it's not just every PT can just do it.
Correct, and it's not. So we first go to school and we are physical therapists first, and then we have to take additional coursework and education afterwards to get our specialty. And so there's many different avenues to do that, but those of us who are pelvic floor physical therapists have specialized training to do more of the muscle assessment with our manual techniques. Other people who do they'll call it more pelvic floor therapy, do more biofeedback, which is just one component of what we can offer. Okay. We can offer, you know, both the manual skills to do the assessment as well as biofeedback.
And what is biofeedback?
Sure, biofeedback is, it's a machine that we can use that reads muscle activity and as an electrical signal, and then that will make an implication based on how well you control your muscle, how good you are at squeezing your muscle or relaxing your muscle. What is your muscle doing when you walk or when you sit or when you go to the bathroom? And so it gives us a visual that we can see and then associate that with your muscle integrity and control.
Okay. Is this something that's been around for a while, or is it a newer kind of type of therapy?
It's been around for a really long time. It's definitely something that is not talked about a lot, so therefore I think it got missed for a long, long time. But you know, the physical therapy world, we're trying to make a bigger presence for people, especially since we're trying to move more into like preventative health.
Right. And
pelvic floor physical therapy, now we're trying to better publicize and let people know about these resources. And there's more of us that are interested in it. And that also helps, you know, get the word out and let people know that we're here, we're a resource for you, and we want you to use us.
Right. Okay. So it's something that people will kind of just shy away from talking about. And
absolutely. How often do people talk about like, oh, hey, when I cough, I pee, or when I do jumping jacks, I leak a little bit? People don't talk about that anymore.
Right. Right. Okay. And so you mentioned like kind of the symptoms and that sort of thing, but who can get this? Who would benefit from this type of therapy?
Sure. So men, women, and children can benefit from this, and that's all ages. There's no limit to how old you can be and have some benefit with your muscles. And again, it can be anything from pain to bladder issues to bowel issues to even sexual dysfunction as well.
Okay. And you mentioned children. So is that, you know, if they are still wetting the I don't know, obviously, all the stages of when they should use the bathroom and that sort of thing, but if they're still wetting the bed when they're 10, could that potentially be a pelvic floor issue and not so, you know, a mental issue or not? That was terrible, but you know what I mean.
Absolutely, I'm with you. It is. It's so integrated for these kids, and the pelvic floor can be a component for them, especially if they have other things going on, like if they have a neurological condition or some orthopedic condition that's impacting their pelvic shape or something like that. Their muscles are probably going to be affected as well. We like the kids to be a little bit older because we want them to be involved in their therapy. Mm-hmm. This is an active thing that they have to be invested in, and you know, have the maturity to be able to talk about how's going to the bathroom, you know. So there's a certain age limit to it, but we do want those kids, you know, before they turn 16.
Right. Mm-hmm. Right. Okay. And does insurance cover this?
It does. Most insurances have a physical therapy coverage plan, and we are just part of that. We are just specialists within your physical therapy plan.
Okay. And how would someone, I guess, do you have to have a doctor's order to get this? Is this something that people can self-refer to? How would they get this type of therapy? Right
now, you do need a physician's referral for it, for insurance to pay for it. We are working toward getting what's called direct access, and that's where you can come to us without having to go to the physician first, which will just make it more timely for you to come and get your services. You've had leakage for 20 years, you've been checked out, now you want to try this pelvic floor physical therapy. Maybe you don't need to go to the doctor because you've been going to the doctor, you just want to come see us. So
Gotcha.
we're working on that. But for now, to let insurance cover it, we do want that physician's referral, and it'll keep us all on the same page as well.
Okay, and is it something you should just ask your primary care or your OB or something like that? Just ask them, hey, I heard about this pelvic floor therapy. I think it might help me.
Absolutely, and any doctor can refer to us. It doesn't have to be a specialist. Your primary can do it, orthopedics, urology, OB-GYN, GI, anybody can refer to us, and it'll fit within what we do.
Okay, great. Well, thank you so much for being here.
Thanks for having me.
I'd like to thank Jenny for being here and giving us some great information about pelvic floor therapy. Up next, we have Dia Frederick to talk about pediatric feeding.
The North Shore. It's our place, where finer things are sometimes the simple ones. Social, sweet, and spirited, but always in harmony. Around here, life is about great things coming together. St. Tammany Parish Hospital and Ochsner, collaborating in the name of community.
Welcome back to Healthy Living, brought to you by St. Tammany Parish Hospital. Our next guest is Dia Frederick, a speech therapist with St. Tammany Parish Hospital Outpatient Rehab Services, here to talk to us a little bit about pediatric feeding. Welcome, Dia.
Thank you.
So first, can you kind of give us a little bit of your background?
Sure. I have my master's in speech therapy, and I obtained that from Southeastern Louisiana University. Proud local. I've been doing this for 13 years, but pediatric feeding is something that we are just now getting into. Just as a little bit of history, it's always been sort of an occupational therapy realm, and now speech therapy is starting to really delve into it also. So.
Okay. And so I guess let's go into what is pediatric feeding? Why would someone need that type of therapy?
Well, first of all, let me just give you a few little statistics. 25% of all children have some issue with feeding. That's a pretty big number considering people don't know what this is.
Right.
And then 80% of the children that we see with developmental delays, any kind of disabilities, have feeding issues. So it's actually more prominent than people realize. But as far as feeding, there's some confusion between food aversion and picky eating. A lot of people say they're picky eaters, they're going to outgrow it. There is something that is normal picky eating. And what that looks like is your child is typically developing, eating everything they're supposed to. Between 18 months and 3 years, they say, no thank you, don't want it. And they start to develop food preferences. So they may just want to eat chips and junk food, and that's when you start to hit chicken nuggets, French fries, those kids. Now, those are your typically developing picky eaters. And the key with that is that it is a phase. So they're normally developing, they're in this phase, and they come out of it. So those kids do grow out of it, if for lack of a better word. Our kids with true food aversions don't grow out of it. You'll start to see as they're developing some issues, and there are many reasons why, which I'll tell you, but you'll start to see that they're not developing so well. They're not eating all the foods that they're supposed to be eating. They're not transitioning from liquids to solids very well, that kind of thing. And then once they start to get to real food, real table food, is when you start to see the food aversion. And what I mean by aversion is it is almost painful. It is not the no that you see in a 2-year-old.
Right.
It is, you see it in their eyes, you see it in their body. There are lots of signs that show a true aversion to, this is harmful to me and I don't want it.
Okay.
So there's a big difference, and I don't really want that. I'd rather something else, and I can't handle my body cannot handle this.
Okay.
So parents don't know the difference. Pediatricians don't know the difference, so it's really important that we are bringing this to the community to let them know, here are the signs that you need to look for, and just in case, get a professional opinion. So some of the signs and symptoms that I was talking about for true food aversion, there are signs of distress and disengagement in feeding, which are a little bit milder, but it's sort of the precursor to here comes the big stuff.
Okay.
So some things that parents can look for is just being really tired at the table, because you want your kid to be alert. And so if everybody's at the table and the kid's just kind of tired and lethargic and not really interested and disengaged, that's a sign that there can be a problem. Things like squirming, looking away, hands up, they just don't want it. Those are all signs that, hey, let's start looking a little bit more into this. Also, things that normal babies, normal kids do, like some spitting up, things like that, that's not always a benign thing. That can actually be a sign that, hey, we have some other issues going on. So some bigger major distress signals that you want to look for, which are a lot more apparent: coughing, choking, spitting up, gagging, their body stiffens, any change in respiration, any change in their color. Look for those true body signs. Their body will tell you whenever there's a major issue, and that's definitely when they want to seek advice, because that can lead to serious issues, serious aversions. So
Okay, and I guess do we know what causes these aversions? Like, because if it's a physical issue that they're having, like, what is the issue that's causing these?
there are 4 main areas.
Okay.
So every kid is different. Every kid from in utero has developed differently. So many things can cause it, quote unquote, cause it. But there can be medical issues. There can be things like reflux. The child can be tube fed. There can be lots of medical diagnoses, have one of the symptoms is feeding issues because of that. Also sensory issues. We have lots and lots of kiddos with sensory issues these days, and that's a whole other segment. But if they can't handle the sight of it, the feel of it, the texture, the smell, the feel of it on their hands, kids are supposed to play with their food, unlike a lot of parents want them to do. They're supposed to be messy and play with their food. They may not be able to handle any of that, and if they can't handle that, then they're not going to get it into their mouth. Also environmental and emotional sort of components. So there's a connection that happens with a baby and a mom the first time that mom feeds that baby. And it's social from that point on. Social eating is a big thing with us.
Right.
And so from that point on, it's social. There's a connection that's supposed to be made. And what we're finding with a lot of these kids is that if they don't have that connection, they don't have the trust, and then we start to see serious feeding issues with them. But like you were saying, one of the big things is a mechanical issue. So the child may have a cleft palate, the child may have a cleft lip, the child may have a tongue tie, all these mechanical things that could go on that are responsible for a child not being able to successfully take that food in and swallow it. But also mechanical, meaning they can't necessarily get the food to their mouth. You might have an independent little fella who doesn't want anybody to feed him, and if he can't get the food to his mouth for whatever reason, he's going to stop eating.
Right.
So lots of factors can really be involved, which is why it's not as easy as telling your pediatrician, my kid's not eating.
Okay. And so is that something, that's what I was going to ask next. I assume they need a physician referral for this type of therapy. When they go to their physician, should they say, not just say like, my kid's not eating, what do I do? Should they say like, hey, I would just really like to get a consult for that? Because I mean, if it's not that, if it's something easy where they're just being picky, y'all can tell them, nope, it's just picky. Y'all don't need to come back.
Absolutely. And the evaluation is very non-invasive. We're not doing any kind of modified barium swallow study, or at this point, I mean, just to have the child come in, what the parent should expect for the evaluation is have the child come in, bring some preferred foods that they are eating, because we do want to watch them successfully eat something. Bring the foods that they are eating. It also lets us kind of evaluate, oh, this child prefers crunchy stuff. This child prefers soft things. This child, they may have what we call a color diet where they all only eat the same color food. So it really does tell us a lot when we get to see what they do eat. And if mom comes in empty-handed, then we know we have a big problem. So that tells us, we're starting from square one.
Right.
And this isn't unheard of for tube-fed babies either. You can get a baby off of a tube with the right type of therapy. It's intense, but it's possible. So, it's important for the parents to bring in a journal of, how they act, how they look, where they eat, what they eat, if it's consistent, if every day they want something different, if it's something they've eaten before and now they've stopped. Journaling is a big thing. So I would highly recommend to parents to, if they're suspecting it, get a good 2 weeks, I would say, of what their behaviors look like, what their food intake looks like. If anything's going on new in their little life, maybe a new baby, or mom and dad may have gotten a divorce, or who knows. those kind of things. Journaling is super, super important.
Okay.
The food diet that they do eat is super important. And if they bring that to the pediatrician and say, listen, I'm armed here. I have,
Right.
you know, written proof that my child is not doing what he needs to do, they probably won't have a problem referring.
Right.
And it's within, I mean, a parent is the child's best advocate. So I would say to the parents, push, push, push. Like I said, it's not an invasive evaluation. Tell your pediatrician you're really, really concerned about this, because a lot of times what they'll do is say, oh no, they're growing fine. Well, I have a picky eater myself, picky eater. I have a child with food aversion. And I was told he'll outgrow it, and he's growing fine. Only because I've been able to manipulate his diet enough to know that he's getting nutrition.
Right.
So if I didn't, he would live off of potato chips and, you know, veggie straws and.
Right, right.
So
which is not getting them the nutrition that they need.
No. And I mean, that's not what we consider typical or normal.
Right.
So push your pediatrician, be, you know, armed with the information, and pediatricians are there to help. They really are. They're not there to
Right.
prevent children from getting the services that they need. A lot of times they're just not familiar with the services that they need.
Right.
So the parent needs to be the best advocate, and if they truly in their gut feel like something's not right, you know, we have flyers a lot like this that are laminated that you can bring to the pediatrician's office. So if any parents want to stop by and say, hey, I'm really concerned, do you have any information I can bring to my pediatrician? We do have that information, and we are happy to pass that out. And that is something the pediatrician can keep. So for reference.
And is this something that y'all had to go through special training to do?
OT and speech is a little bit different, but basically it's based on our CEU, so our continuing ed. So if it's an area that we're interested in, we go to continuing ed just to learn a lot about it. And there are a lot of different approaches to it. So it's kind of finding either what you're comfortable with as a therapist or what you really see work with that child. So for one child, it may be more of a motor approach, and for another child, it may be more of a sensory approach. So it depends, again, on those things that I said from the beginning. What is the root of the problem?
Right.
And there may be many roots of the problem. And as you're uncovering what's going on, it might be layer after layer after layer, but that's what these kids are all about.
Right. And so is that something, I would just, like you said, every kid's different, so I assume it takes a different amount of time for each kid to see
Exactly.
improvement. But do you have a generalized, you know, usually they'll be able to fix, is it something that I guess is fixable? Like eventually it won't be lifetime therapy.
Right.
And that sort of thing.
Fixable is a hard word.
Sorry.
No, it's okay. Their ability to cope with things gets
Okay.
better. So they learn, this is not going to kill me. I can tolerate this. If I'm, you know, a grown man at a party, I know that these are my foods I can choose from, and I can be, you know, find something I can eat.
Right.
So they may never eat oysters. I don't ever want to eat
Exactly.
oysters.
Neither do
So,
I.
you know, we all have our thing where
Right.
our line that we draw and say, not going there. And that's fine. That's
Right.
perfectly fine. That's kind of what it gets to.
Okay.
They learn how to find different things in life that they can tolerate in different situations, and they survive just fine. Now, as far as the duration of the therapy, that's where it gets tricky because, like we said, every kid is different. Of all the things that we do, this is probably one of the things that takes the longest, just because there's so much trust that has to be developed. There's so much exploration that has to happen before food ever really gets to your mouth. So it's a lot of times parents say, why isn't my kid putting food in their mouth yet? You know, well, they have to be able to tolerate it on their plate without throwing up first.
Right.
So, you know, it's little bitty baby steps, and it's super important that you get to the right therapist that you trust that can explain that to the parents. Because if they can't, the parent's going to sit back and look at that therapy and say, I'm completely wasting my time. So a lot of times food aversion therapy doesn't look like that type of therapy,
Right.
you know, until you get to a certain point where that kid is okay bringing it to the mouth, starting to explore it in the mouth, just like a baby does. A baby explores in the mouth, and it's the same thing. It's the same thing. So, I mean, it can be, there have been success stories in weeks. There have been success stories in months. There have been success stories in years. So it really all does depend on how complicated the situation is.
Awesome. Awesome. Well, thank you so much for being
You're
here and
welcome.
giving us that great information. I'd like to thank Jenny and Dia for being here today and sharing this information about some specialized therapies that we're offering at the hospital. This has been Healthy Living, brought to you by St. Tammany Parish Hospital. I'm your host, Amanda Paxton, and we'll see you next time.